Good afternoon and welcome back to the second section of our NHS West Yorkshire Integrated Care Board meeting in public here at the Life Centre in Bradford today. And thank you to colleagues around the table for their contributions so far to the meeting, our guests and visitors who've joined us in person today, and for anyone watching live online or on the recording of this meeting. All our documents are available online to view. It's part of what we wish to do in terms of being open and transparent as an integrated care board and overall in our work in our health and care system. So we're now on item 7, which is my chair report. Board colleagues around the table are aware that I put this together particularly as a record of our governance activities, our partnership activities, and any response that we have particularly to NHS guidance and information. What we have particularly is a note there on our response and work around the NHS England Fit and Proper Persons Test framework. It's something we've adopted as a board from the start, but we are responding now to specifically the framework that came out in August. You've also got a note there of our visit from Lord Markham from Department of Health and Social Care in July. And thanks to so many people who worked with us that day, these kind of visits don't happen by chance, and nor do they happen in a matter of days. There was a lot of planning there, and I'm really pleased and proud that we managed to showcase the work that Airedale Hospital is working on in receiving money through the new hospitals programme nationally on their RAC issues that they have. We also heard from Bradford District Care, NHS Foundation Trust on their Linfield Mount capital needs, which their Chief Exec Therese Patton talked about a moment ago. Our colleagues from Calderdale and Huddersfield Foundation Trust shared their work on Calderdale Royal Infirmary and Huddersfield Royal Infirmary, and Leeds Teaching Hospital particularly showcased their work, again receiving national funding for the new hospitals programme. And I might be sounding like I'm labouring the point, but we have a number of capital priorities within our system, and what you heard there is some are funded nationally and some are not and still seeking funding, and it relates back to a point that we've just had in our mental health discussion, which we may well touch on again later for finances. There's also in that document for the first time highlights of our board level service visits that we've been taking place. There are so many more visits that have taken place than are listed in that report, but hopefully for members of the public and particularly for members of staff, it's Kate's earlier point about workforce or our people as well, about how we're trying to get out and about and be visible, engaged as board members, understanding places, services and the breadth of the NHS and beyond as well. So I hope that's helpful. A couple of things I wanted to just note, just a reminder, and hopefully this is assurance, but it came up in our partnership board meeting back on the 5th of September about queries around maternity, safety and services, that we have maternity safety champions on the executive side, which is Beverly Geary, and on the non-exec side with Becky Mulby. And that is all part of national requirements, but colleagues here go above and beyond that. Bev has already talked today about our work around maternity services, including in our AGM today, and may well touch again on that again later. And also just a confirmation of a change in roles, which I'll report more fully on in November, that Becky Mulby has now taken on chair of the ICB Quality Committee, and Majid is a member of that committee, so we're switching roles there and going forward. So I hope that's a helpful record. It's also for me trying to record good work that Laura and colleagues are doing on the governance side as well. I don't know if anyone has any questions at all. No. Always silence. I'm going to just 30 seconds, Brendan. You were with me on the Lord Markham visit. How did you find it? Because what the feedback from the Department of Health was that's the first time they had been on a system visit rather than just meeting a sole organisation, and they really reflected on our can-do attitude, Rob, which I really welcomed hearing about that day. I don't know, Brendan, how you found that visit.
Very much that. It was a bit of a, come on, everybody needs to crack on. I think he was equally frustrated by some of the overly bureaucratic processes that I think are in place for a reason, but actually slow us down. He did see that there was a can-do attitude here, and that despite being frustrated by some of these delays, we were moving forward with this. I think he liked the breadth of our conversation, and that I think as a system, we had a collective view on what our priorities were and where we should be spending our money and how we could potentially do things differently. But we were asking him to support us in our endeavours and to use us as a test bed for cracking on.
Brendan, thank you. And also very specific on figures on funding as well, which was, it was candid and open, which was what was required. Okay, thank you. So I'm going to move on now to Rob's report, our Chief Exec's report in item 8. So Rob, I don't know what you'd like to highlight with us in your report, and then colleagues, if you have any questions or comments, please just let me know. Rob.
Thanks, Cathy. Welcome the conversation around the report today and some updates that we can provide, given this was circulated a week ago and things continue to develop on a daily basis. So I think it's worth reiterating here, as we did in the annual general meeting, our collective support for being able to speak up. There's been a lot of discussion and debate following the prosecution of Lucy Letby for a number of murders of babies and attempted murders of babies at the Countess of Chester Hospital, and a lot of conjecture around the circumstances in that case. But one thing's clear is that people need to be able to speak up and be taken seriously when they have concerns. And all of the organisations across West Yorkshire have been working with their staff to make sure that they understand that that's part of our culture. And I know that the board is also committed to ensuring we have the right sort of culture and leadership in the system, which is one of the reasons why we continuously talk about the values and behaviours expected of people in the organisation and across the system, that those values and behaviours are tested in senior appointments and the appointments within this organisation, and that they're covered induction, appraisal and all points in between. Worth also reflecting that there's a lot of debate about regulation of managers, and I've also highlighted the changes to the GMC, suggested changes which would come in from next April to the GMC Good Medical Practice guidance. Regulation of managers is something that's discussed periodically. There are many people sitting around this table who are regulated. There are many of the chief executives in our system who are regulated because they are clinicians. Brendan, for example, is one of them. Sarah's another. And I think that they go about their business and are able to be chief executives. Mel's another, in ways which regulation doesn't prevent them from having the capacity to get on with it. If managers are going to be regulated, I think that's fine. I think that's fine. We need to do that in service of something, though. And, you know, a common set of standards, professional support, development, culture, all those things are important to consider. So let's see what happens with the government. But the prevailing wind would suggest it's probably going to come at some point. And it'd be useful to learn from those leaders and managers around the table who are regulated, what that means for them in their professional lives. Also worth reflecting that since this was written, this report, there's been a couple of further developments which have been shocking. The first is the, again, I talked about this in the annual general meeting, but it's worth repeating in the board, is the report into sexual harassment in surgery, which, again, all of our organisations are following up, and we're doing some collective work through the West Yorkshire Association of Acute Trusts and the medical directors on that issue specifically, and we'll follow up across the board, because if it's happening in surgery, we know it will be happening in other places too. And through the Women's Network, through our leadership, we'll ensure we're going to take the right actions to reduce the likelihood of this happening and hopefully eliminate it. It's also worth reflecting, I think, on probably one of the most shocking things we talked about earlier in the previous session, intersectionality, and the intersectionality of people from minority groups, ethnic minority groups, and learning disability, according to the Race and Health Observatory, is that your life expectancy in England, if you have a learning disability, is 64. If you're from a racial minority group, it's 34. 34. So we need to continue to keep reinforcing the importance of intersectionality and inequalities in every single thing that we do. And the fact that that is one of our statutory requirements and one of the things that we keep highlighting in the year ahead and our strategies is something that I think gives me some confidence that we'll continue to be challenged by these things and also act on them. I mentioned in the report that reinforced autoclaved aerated concrete was something which we'd been involved with for some time. I know that Brendan, in a former role, did give a senior leader in the NHS a piece that had fallen off his hospital as part of one of their visits. And we've been dealing with this for some time, but it's become a national issue again because of what's going on in health and in the wider sector. We've known about it in hospitals for some time. We've been asked for some further assurance. I just wanted to ask Jonathan to give us an update on what we've been doing around other health buildings and the existence of RAC and any assurances that we can give to the board at this point.
Thank you, Rob. So we've been assessing with all of our 10 provider trusts whether there is any presence of RAC in the buildings. We've also been working with NHS Property Services to understand what the position is with regard to primary care estate, particularly around GP practices. The latest information that we've got is that there is no prevalence of RAC in any of the West Yorkshire primary care GP estate. There is a further piece of work that we're doing, supported by some of our advisors, on what's called 3PD, or third-party developer estate, which is a private sector-owned estate who lease premises to GP practices. So there's a piece of follow-up work going on with regard to that. So we think we're in the right place at the moment in terms of at least understanding what the baseline issues are.
Thanks, John. I thought it was important, given the profile of this, that we took that into account. We should also recognise that as schools are affected, our staff are affected because they care for their children who go to schools or don't if they're not open. So we're keeping that closely in view, working with local government colleagues too. Today marks another day of industrial action, and this week we see joint action from consultants and junior doctors and further action in the following weeks. You'll see in the report that I've highlighted that that does have a consequence for us. As I said in the annual general meeting, this is an issue between the British Medical Association and the government. It's their dispute. We cannot solve it here. We do feel the consequences, though, as do our patients and the public. And there's three I've highlighted in the report. The risk of harm for staff and patients increases as we go into the disputes, which now lasted nearly a year. And if people have had multiple postponements, our staff have had to make multiple postponements, that increases the risk of low harm, psychological harm, distress. The second impact is that the more that we do this, the less we have the capacity to tackle the backlog on waiting. And the third is that as we are constantly managing this process in our hospitals, our mental health providers, in general practice, across our systems, we're not focusing on productivity, we're not focusing on recovery, we're not focusing on safety, well, we are focusing very much on safety. We're not focusing on the things that we really want to be focusing on. So there's a triple impact of the industrial action, which, although it now feels like it's become a bit business as usual in terms of dealing with this, the consequences are felt on our business and the delivery of services and on patients and the public, and we shouldn't lose sight of that. And it would be good if there was some hope of some resolution to the dispute. In terms of other areas, the Integrated Care Partnership, MOU, I would celebrate, and the benefits and opportunities that gives to us. Yesterday, myself and Fatima were at an event led by the Mayor and Dr. John Wright from the Applied Research Collaborative in Yorkshire and Humber, which has brought to us a scientific advisory group brought from all of the resources in our universities and research collaboratives, which will advise the combined authority and ourselves on what's the best evidence possible for the work that we're doing so that we can make evidence-based decisions and that we can evaluate the things that we do. to make sure that they make the biggest difference to us. That's one example of the sort of developments that we're bringing. Fatima's roles and the work that we're doing on the economy and jobs, etc., is another. Our work on system of sanctuary continues to be important. Local authority colleagues have been in discussion with the Home Office and their accommodation provider over the increases that we're seeing in people being dispersed to West Yorkshire who are seeking asylum and people who are refugees. And people need to be living somewhere and they need to have safe services. We continue to work to try and ensure those services are safe. The board will be aware of our serious incident report that we had around the dispersal of people to Manston, and we covered that at the last meeting. We continue to have concerns that we're discussing with the Home Office and their accommodation provider around safeguarding and doubling up of people in hotels, which we'll continue to discuss and oversee through the Quality Committee and with our local authority partners. Finally, the operating model work continues. That is driven by several things at once. If we weren't required to make a 30% reduction to our running costs as an organisation, we would still be looking at the operating model, because we have providers coming together to collaborate to deliver services together in different ways. At the session this morning, some of our colleagues and some of the families talked about it'd be better if we had an alliance of people working on mental health in our place, like they do in some other places in West Yorkshire. We also have the delegation of further responsibilities to us as an organisation from NHS England. So we've seen that on pharmacy, optometry and dentistry. What we're now seeing is, from the 1st of April, a suggestion that we pick up responsibility and the accountability for specialised services. And given the changes in NHS England, need to catch up a little bit on this, that the staff are still hosted in NHS England. So we'll need to make a decision around whether we think that that's a good thing to do or not. If board members were to think about it in a way which fits with our previous experience, Anthony and his team very much feel like they work with and for us in the system, but are employed by NHS England. It's the similar sort of approach in that we would be accountable for, the moment we're accountable for performance, improvement, etc., but we're supported by Anthony's team. We would be accountable for specialised commissioning, but the team would sit in NHS England. And we may want to return to the risks around that, given the scale of the resources and the fact that it goes beyond just West Yorkshire later on in the private part of the meeting. I think that's all I want to say, apart from, you know, there's an ask there for people to become champions for our programmes around suicide and suicide prevention. So if people do want to do that, then please get in touch. Thank you.
Thank you very much, Rob. I was going to reiterate that in an invitation to board members to become suicide prevention champions, and you've already provided the web link to start the online training, which is really helpful. Thank you. I also want to thank many colleagues around this table and elsewhere, including Tim and Kate and yourself and many others who are working on the nationally required 30% reduction for all integrated care boards, all 42 in this country, including us. And I know there's been a huge amount of work that has taken place alongside the day job as well, which is very much appreciated. Does anyone have any questions for Rob in relation to his report today? No. Bev?
It's not a question. Excuse me, it's not a question. I just want to point board members to the point 5 of your report, or 50, an Under Children and Young People's Project Hope. So we, the West Yorkshire ICB, were successful in becoming one of 10 ICB pathfinders to support young people leaving care. And this is a really good initiative for people that have been in care for most of their lives. I would ask members of the board, and we'll go back to your organisations if you're not within, within the ICB and others, and people that may be streaming live, to consider becoming a pathfinder. So what that means is you offer a placement for 6 to 12 months for school leavers, for care leavers aged between 6 and 25 within West Yorkshire to access career opportunities, and particularly in health and social care sector, and to harness the young talent. So I just wanted to point that out, Chair, because we've got quite a lot of people that we're trying to engage on this really brilliant project, and to support them in West Yorkshire would be a really good thing for us and for them. Thank you.
Thank you. And for those of you that maybe didn't attend our partnership board meeting on the 5th of September, we heard from someone with lived experience who was also part of that project as well, which was really powerful, and also from a number of local authority colleagues who've been having positive experiences in offering these placements. Harris, did you want to respond on that? Oh, okay. Let's go to James, and then we'll come over to you, Harris, and then Robin.
Again, it's not a question, but it's picking up from the paper in terms of asking for an update on the vaccination. It's just really just to highlight to board and to others that the autumn campaign has commenced for both flu and COVID vaccination. Due to concern for the kind of new variant that's highlighted in the paper, the BA 2.86 variant, we're asked to bring this forward and do it faster. So I just want to thank our primary care networks, our community pharmacists, our trusts and community teams across West Yorkshire for kind of stepping up to do that. Because, so from last week, the care homes were started and we started going out to our care homes there. And then from this Monday, it's been wider there for those who are eligible to that. And it is about learning from kind of previous year or the previous campaigns there, learning and to ensure that kind of we get the vaccines out to those who are eligible and can take that up there as well. So the aim is to finish by the 22nd of October for care homes and the end of October for, generally, but it will carry on after that there. So I just wanted to highlight as requested in the paper.
Great, thank you very much. And as health and care leaders, I encourage you to promote that far and wide. Thank you. Harris, you said you have a question.
Just on the industrial action, or healthcare students are still required to make up their mandatory placement hours, and just seek an assurance that there's support available for them within the NHS trusts and universities, that they won't be asked to do stuff that's beyond their ability.
Don't know, James, if you want to comment on the professional elements of that particularly.
Yeah, no, Harris, I mean, I think one would not expect anyone to do any sort of procedure or care that wasn't within their kind of professional ability there, basically as an undergraduate there. The same as anyone who was postgraduate as well there. So I think it's the same. One would expect that from organisations. I would know that would not happen across West Yorkshire. Speaking with the medical directors, I don't think there's any expectation of that. I think it is about how we support our organisations during this time there. But it's not about going above and beyond in terms of your professional duties or what are the expectations there.
Great, thank you. And Harris, another reminder, thank you, of our university population and also the importance of placements. Robin.
Yeah, thank you, Chair. I just want to build on Rob's comments about migration and asylum, just to say that there is an additional range of challenges that I think will test us on our system of sanctuary, but I think we will be determined to stick to it. But there is the doubling up in hotels and the need for proper health checks and assessments there. There is not just the increase in dispersal, but the increase in decision-making linked to trying to reduce the backlog with sometimes only 5 to 7 days' notice, and the risks for all local authority, voluntary sector, NHS colleagues around homelessness presentation, around people moving out of accommodation, dispersed accommodation very rapidly, and that's likely to accelerate. There's an increasing issue that we are working with the Home Office and the supplier on around age assessment and the identification of individuals that have been assessed as adults but are actually children. and the implications for that, both in terms of that individual being in and their well-being, being in a hotel primarily, but also the duties of the local authority to then have them as a looked after child, and leaving care responsibilities, and that's an issue. And then the final thing is, you may have seen the recent judgment against the Home Office and Kent County Council around the number of children and young people seeking asylum who are particularly in Kent, and the now escalating relocation of those children and young people to all parts of the country, and that will include West Yorkshire. So we expect an increased number of children and young people with the support needs that they will have. So just to highlight, unfortunately, this will be more challenging than ever, I think, going forwards. Thank you.
Thank you, Robin. There was mention of taking that to Quality Committee for oversight, which I know was done before. Are there any requests today, particularly for people working in services or place committees? It feels to me this is a watching brief going into winter as well. Is there any specific request of colleagues around the table?
I think, no, take it there, and I think we'll be picking it up in all our place committees. Thank you.
Rob?
Yeah, the board should be assured, and looking around at the faces of colleagues who work in place, that the operational reality of dealing with very rapid arrival of people into our, places, many of whom will have faced trauma, some of whom will have faced torture, some of whom will have had incredibly difficult journeys to get here, is a matter that they're dealing with in their places, collectively, and with the right approach. What we're trying to do is to make sure that we have as much notice as possible, and that the arrangements reflect any information that's available about those people as they arrive with us. That hasn't always been the case, so we've had to intervene and make rapid assessments and put things in place to keep people safe and well. So I think that operational reality feels to me that something people are pretty good at. I think what, as Robin says, we need to do is to make sure that we're being more planful about the likelihood that there'll be more people arriving who need more support and help, and what that actually means for us. I know we've been talking to colleagues regionally and nationally as well about what that might mean for how resources flow subsequently. Okay,
thank you. We'll have it as a watching brief, and thank you, Robin and Rob. I know you've had conversations even over this weekend. This is how passionate you are and committed you are to making sure that we do this right in our system. We've made a commitment to be a system of sanctuary. And Robin, we've talked before about whether you want to come to partnership board and that more broader discussion about being a system of sanctuary, and we could revisit that in future. I know our colleagues in local authorities also continue to work on safeguarding under their statutory duty, as well as we do in the NHS, and perhaps that's a point of exploration into winter and into the new year as well. Okay, thank you very much for raising that. So colleagues, we've got around 40 minutes left and still a lot to do. I'm grateful to you for your time today. It's always the nature when we've got a big agenda, and today we've also brought in our annual general meeting. We've now got items on system performance, our integrated performance dashboard and corporate risk register, including our financial performance with Anthony, Jonathan and Laura, winter planning update from Anthony, for the record and any immediate queries, our committee AAA reports, which gives you a snapshot of what's been going on in parts of our governance, and then some approvals around terms of reference. So let's see how we do together in trying to land all that by 4:30 or so. Okay. Anthony, Jonathan, and then Laura, are there any highlights you want to make for those reports? And thank you again for continuing to take on board our feedback, Anthony, to make sure that this document is useful to us all.
Yeah, thanks, Chair. And I am conscious of the time, but I'll just make some brief introductory comments on the Integrated Performance Report. And if I can just thank Becky Malby as well for providing some comments and questions in advance, which I'll touch on briefly, if that's okay. So just to note that we're continuing to develop the report. This builds on the new format that we agreed at the last meeting of the board in July. Colleagues might recall that we set out a plan that in alternate months we'd have a report on the a detailed report on benchmarking, how we compare with other systems, and that was in the July report, and would alternate that with a report on progress against the 10 big ambitions which underpin our strategy. So this report includes that update on the 10 big ambitions. Just to clock, there's a slight mix-up of slides in the narrative on that. I think that the narrative on ambition 2 is in amongst the ambition 1 slides. So just to note that as you're trying to make sense of the narrative. So, and just to sort of navigate you in terms of what data we're looking at, the report contains the most up-to-date available published information, and that means it actually refers to different periods depending on the publication cycle for each metric. Most of them are around the sort of June-July period. Some of them are somewhat older than that. So the IAP data, for example, just looks at the period back to January, which clearly isn't very helpful. We do think some of these ones, in particular the IAPT one, there should be more up-to-date information available. So we are discussing that with the data provider at the moment, and we'll look to get to make sure that the most up-to-date information is available in future reports. So I think that's the sort of main points to note in terms of the format and the progress of the report itself. I'll just pick out a couple of headlines in terms of things I wanted to draw to the board's attention on the data itself, starting with urgent and emergency care. And I think I just wanted to flag that there's a generally positive picture around reducing long waits in A&E. The 12-hour A&E rates are showing a reduction. And we actually have some further positive developments in the UEC system. So Brendan has a shiny new A&E department at Huddersfield Royal Infirmary, which is due to open in the coming days and will have a significant impact on the experience of patients using that department. I visited it myself yesterday and was really impressed by just how great an improvement that's going to offer for local patients. We also have secured funding for a new urgent treatment centre at Airedale Hospital. So there are a number of developments there which are going to, I think, really help us continue to make improvements in UEC performance. On cancer, I just wanted to note that we've got a generally positive picture of performance in comparison with other parts of the country. That's not to say we're actually hitting all of the standards, we're not, but in terms of the progress we're making to recover the backlogs caused by the pandemic, I think providers of cancer services in West Yorkshire are doing relatively well. Nationally, there's been an agreement to actually change the standards which monitor cancer, access to cancer services. The 10 standards will be reducing to 3 from October, with a particular focus on the faster diagnosis standard and the 31 and 62-day referral or diagnosis to treatment standards. So just to note, that will be a change in the detail of the reports in future. I should say the Cancer Alliance is very clear that they'll continue to monitor, shadow monitor, if you like, all of the existing standards as contributors to the ones that will be nationally the sort of the point of focus in future. Moving on to elective care, just wanted to note that we're making progress to reduce long waits. So 78 weeks waits should have been eliminated by March this year. You'll see in the report that we still had 75 in June, and we have made some further progress on that in recent months, looking at management data. But I do want to flag that progress with that is being impacted by industrial action, as Rob suggested in his Chief Executive's report. So while we had expected or hoped to have eliminated 78-week waits by this month, I think it is going to take a few weeks longer and is still subject to the further impact of industrial action. And I suppose just given the context of today's meeting and the focus on mental health, just wanted to just draw colleagues' attention to the indicators on IAPT's waiting times and early intervention, which are all positive. I think we're ahead of the national standards or benchmarks on those services. We are looking at what further information we can include on children and young people's mental health services in this, and that's being slightly limited by what's publicly available. But again, by the next report, we're aiming to include a bit more detail on children and young people. So I could go on, Kathy, but I'll stop there given the time and ask if there's any questions on that.
That's great. I'm going to, I'll note questions. So, Becky, I've just seen your hand go up, and then Harris, and then Mel. But I do want to invite Jonathan and Laura just to give us an overview, and then we can take those set of documents as a bundle. Jonathan, over to you.
Thanks, Chair. So, in terms of the financial position, we continue to have a very challenging financial position this year across the system, both in the ICB and across a range of providers, primarily the acute hospital service providers. So the data we've got in the pack relates to the position as at month 4, so as at the end of July. And I'll do this in sort of 4 separate parts. So the first is what's the year-to-date position? So as a system, we had a year-to-date actual deficit of £36 million. That compares to a plan of £9 million deficit. So as such, we are £27 million worse than our plan at month 4. So that's the first thing. That variance from plan is primarily in the ICB and 2 of the acute. Sorry, yes, of course, I'll move this. Is that better? Okay. So the £27 million adverse variance to plan is in the ICB and in 2 of the acute hospital providers. So that's the year-to-date position. Just to recap on our plan, so as an ICB, we agreed a £25 million surplus plan. That was offset by a combined plan deficit in our NHS providers of 25 million. So as a system, we had a balanced plan, and that was what we signed off at the start of the year. In terms of a forecast, since the start of the year, we've been reporting a break-even position on the ICB, which is £25 million less than plan. And that relates to the system risk or that improvement in plan that we signed up to as a board at the start of the planning or at the tail end of the planning process. Providers are all still forecasting delivery of their plans. What that means is as a system, we are forecasting a £25 million deficit and have been doing for the last few months. Supporting that, we continue to look very closely and rigorously through the Finance Forum at what the risks and opportunities are that every organisation is facing. And we continue to report that through our system executive meetings and also through the Finance Committee. The current most likely assessment of risks and opportunities suggests that we are holding up to £90 million worth of net risk against plan at the moment. And the paper in the pack describes a little bit further about where those areas are. In short, though, they are around, and some of these issues we've already talked about through a different context today, they are around the impact of industrial action in terms of the direct costs of providing cover. It also relates to the loss of income related to the loss of activity, again related to industrial action. We have experienced instances whereby the levels of inflation that we're seeing in our provider cost base and indeed in the IC cost base is greater than planned and nationally assumed levels at the start of the year. We are continuing to see both price and activity pressures in the independent sector, in continuing healthcare and also in primary care prescribing. And we also have some slippage on efficiency on our efficiency schemes. Those issues, to a certain extent, are prevalent and common across most ICSs across the country. We are continuing to explore mitigations. Those mitigations, that exploration is now supported through a system transformation and efficiency group that we spoke about probably 3 or 4 months ago now. So that's a group that's been set up that's jointly chaired by Carol and James, bringing together a multidisciplinary team. And we continue to review the position both through the organisations, through places, through the Finance Forum, through the System Oversight and Assurance Group and through the Finance Committee. So that's the position that we're at on revenue. Just to conclude it, we do continue to both achieve on a year-to-date basis and a forecast basis our mental health investment standard obligations. Our agency spend is within plan and within the NHS England cap. Our capital position is in line broadly with plan, although there is an emerging risk around how NHS England distribute funding for leases that are now have got to be capitalised this year, which is an in-year issue. So we need to understand that in a little bit more detail, which we will do in the next few weeks, we hope. And the final thing, which again was referred to, we continue to develop the work on the medium-term financial model. That will be going to the System Oversight and Insurance meeting in September, the Finance Investment and Performance Committee in October, and back to board in November.
Thank you, Jonathan. I'd always welcome how you, in an accessible way, explain system finances for a £5 billion budget on how we bring so many people together to work on this. So I appreciate that. We'll have some questions now, but in the private setting later, we'll also get into more detail on that because of the nature of the finances, and it is a work in progress moving feast. Laura, over to you on the corporate risk register. What would you like to highlight? And just before you start, I've got Becky, Harris, Mel and Majid. Anybody else want to comment on item 9? So I've got a no. Okay. All right. Laura, to you.
Thank you. I'll just run through a few highlights. So this report marks the end of the current risk cycle. As always, it's made up of a number of component parts. Firstly, the main corporate risk register, and then we also have risks that are sitting on our place risk registers that are either high level because they have a score of 15 plus, or are common across one or more of our places. There are 44 risks for review for you today on the corporate risk register, which includes 3 that are new risks. They are set out in detail within the report, but just to highlight, they relate to the acute stroke pathway in Leeds, the national trajectory to reduce the stillbirth and neonatal death rates, and primary care complaint services. So those are the 3 high-level ones for you. Every risk that is on the risk register has been reviewed by either the Finance Investment and Performance Committee or the Quality Committee, and you will see within the report there is a summary of some of the discussions that took place at those committees, both to give you assurance that they are being fully reviewed as they work their way through, and also to highlight those that were felt to be most important when we were discussing them at the committees. I think the only other thing I just was wanting to highlight today was just, you will remember me saying at the last meeting that we were going to have more of a deep dive into those risks that have a likelihood score of 5. The definition of that is a risk is almost certain and is expected to occur, and we felt that as a number of those had been at a 5 for nearly 12 months, that actually we may well need to move them to being issues and look at the risks that result from that. So that work has been carried out throughout this risk cycle and is continuing. I think you will start to see some of the impact from that this time, and that will continue as we move forward. And we are also planning during the next risk cycle to start to think about how we can develop issues logs in order to try and support the risk register to be focused on potential risks rather than things that have already happened. Other than that, those are the only things I was going to highlight. The details in the report, and obviously the benefit comes from the discussion. Thank you.
Thank you very much, Laura. And for anyone with us in the room today or watching on live stream, a risk register is really helpful for us to understand through committee work. It's making sure that we've got oversight on it. You've heard words today about we're seeking assurance on this. We want to be assured that there's mitigations in place. Colleagues are talking in a very logical way, but it doesn't mean that we don't care. But this is sometimes talking through the metrics and high risks enables us then to have deeper discussions within services and places. So, Becky, you are first on the list to ask a question. Over to you.
Thank you. So let me just bring this a bit closer because it's quite harder to hear. I understand that. All right, so there's some issues that are just around patterns and trends. So if you look at, for instance, and I'm mindful of our question from the public earlier on today as well, if you look at our ambulance wait times, our category 1s and 2s, you know, the benchmark was moved to 30 minutes from 18 minutes. So when we're looking at like for like, it's quite hard to do that over time. So I don't know whether we still collect the 18-minute data, but if we do, I think I'd like to see it so that we can see over years what difference it's making. Otherwise, you just move the goalposts. And we, you know, when we want to in Quality Committee ask about harm, which we do about these issues, I'd really like to be able to see the patterns. So if I look at the ambulance response times, I see where we are in July is sort of where we were last July, and then I look at where we ended up in winter last year. So it'd be really helpful, I think, at some point to have a conversation. Maybe we can have this when we're talking about preparedness for winter, about whether this is just the pattern, in which case we're going to hit those reds again next winter or not, or is this... So when we're looking at our dashboard, I think patterns and trends are really helpful. I think it'd be helpful, Anne, if we could draw some of those out overall. So are there any concerns when we look at those individually versus where we look at those in place? So have we got any places that are sort of flagging up across, as well as, at the moment, I'm having to delve into every single one of them to have a look for it. So that was the first thing. The second thing is when we're looking at things like when we look at our ambitions, when I look at the patterns and trends on our ambitions, all the things that we have authority over or control over, so things like early diagnosis of cancer, we're making good progress. All the things that relate to poverty and austerity, we aren't. So what does that mean for our ambitions? What's the point of setting targets if we can't meet them because we have policy nationally that undermines those targets? They're outside our ability to handle? Or is it that have we got to get real about those? Are there other things we can do about them? So I think we've got two things in the ambitions. There's those things, the ambitions that are absolutely within our control, and those things that aren't. One of the ones that is in our control, primary care, is around people with learning disability having health checks, and we've still got 3 places that are below 50%. That really worries me. It's a really strong indicator for me about health inequalities and how we're treating people fairly. So I want some response to that, please. And the last one was just on the ambitions. It's just the carbon influencing net metrics look a bit rubbish, to be honest. They don't really look like the things that I would think count around. If we're going to be a leader in climate action, those don't strike me as leader in climate action metrics. So I would like, could we go back and have a look at those? And lastly, Jonathan, thank you for the finance report. You know what I'm going to say, which is it's always good to have in the public domain those issues that are absolutely within ours around our own productivity, and those issues where we think the decisions are out with this system. I'm not saying we don't take responsibility for them, but if we have significant impact of unresolved pay disputes, I hate to say industrial action, it sounds like we're blaming the wrong people here, but unresolved pay disputes that have a huge financial impact for us, I still like to see that reported separately from the things that we have absolute direct control over, where we knew those things were coming and we're working hard to resolve them. So we reported those last time, and I think if we could continue to do that, that would be really helpful. Thank you.
Becky, thank you. I'm just going to go over to Harris. So we've got a point on Yorkshire Ambulance Service, ambulance handover times, previous targets and new ones, poverty affecting the delivery of targets. I don't know if, Ian, you could come back on that. LD assessments, learning disability assessments by place, carbon influencing targets. I think this is one for our colleague Frank Swinton to work with us on and develop further. And factors known and unknown when we set the budget and in and out of our control. So I think that's just a very helpful reminder. Harris, we'll come to you and then we'll ask colleagues to respond. Do you want to borrow Mel's? Won't turn off. I'm sorry, my mic won't turn off. This one's working.
Oh, they're on now. Just a point on ambition number 7, linked to ambition number 7.
Okay, I'm using a different mic. Bev, could you come back to us on that, please? Do you want a couple of minutes, or can you do that now for us as system maternity safety champion, as well as perhaps referring back to the work that you talked about earlier, as well as what we're doing with systems and providers? Thank you.
Absolutely, thanks. So I'm going to talk a little bit more about the maternity transformation programme, and then I'm going to come to specifically to Leeds, because West Yorkshire, we are an outlier in terms of neonatal deaths, and that's for a number of reasons. So there's a national maternity transformation programme that was set out to achieve the vision in Better Birth. So it dates back to 2016. So it's a really well-established improvement programme that has local, regional and national scrutiny. So that's the first thing. So in terms of the LNMS, and linking back to the new risk on the risk register that I was going to come back to actually, is we've got a risk that we fail to achieve the ambition set out in Better Birth around halving the neonatal stillbirth rate, or the neonatal death rate. So we were on track before COVID. And then, like the rest of the country, there was a significant impact, and we saw a rise in stillbirths. We really focus in terms of the LNMS. We've got a focused piece of work, but given some of the complexities within our system and some of the choices that I will talk a little bit about in a moment, we're still an outlier. What I would like to reinforce to the board, though, is these are really small numbers. These are single figures, but clearly each one baby death is far too many. So in terms of Leeds, Harris, Leeds is a tertiary centre. We get the sickest babies there. We get babies from not just across Leeds and across West Yorkshire, but out of region and sometimes, various parts of the country. So they're really high acuity and high mortality. But what I would like to reinforce is that every intrauterine death and stillbirth is investigated under the Serious Incident Framework or by a national body. This is reported in detail at each organisation to their board via their quality committees, and it's also subject to system, regional and national scrutiny, so every single death is reported. So, and the complexity that we have in our system, which is different to some other systems, or quite a few of other systems, is about choice. So as a result of cultural and religious reasons, some pregnancies that we know won't result in a live birth continue as a result of women's choice. So often we know this is going to happen, but we still investigate as we would any other neonatal death. I hope that answers your question.
Thank you, Bev. And I know this is something that you continually to look at. We're going to have that through Quality Committee again. It's a watching brief for us, particularly because of the risk and the statistics. And I'd just say for anyone in the room and for anyone watching online, if you're affected by that, because Bev has tried to explain that, and some of it is NHS speak, but it links with the reporting and the requirements that we have, we'll make sure that there's information available online on seeking support with that. Can we come back to the points from Becky? I don't know if, Rob, you want to respond. And Ian, can we come to you first? Thank you.
Yeah, thanks, Cathy, and thanks. But I think they're both really good points. On the point around poverty and inequalities in the strategy, we included those in the strategy because that's what people in the engagement said was really important to them, pretty much all partners. I absolutely recognise that we are one contributor to that amongst a number of other partners, and that's why we put some of those sub-metrics in, like CVD prevention, COPD prevention, and so on. I still think we should have metrics around inequalities in there, but just be clear that actually it's a multi-agency response, and a lot of it relies on sort of national policy as well as local policy. So I think just being a bit clear about that might be helpful. On climate, Becky, you're right. There's a lot more going on than we've written in that slide there, so we can do a better job on that next time round.
Okay. And just to note, at our partnership board on the 5th of September, Ian, you brought a look forward plan. So for everyone around this table and for members of the public, they can see each topic we're going to be looking at every quarter with colleagues across council, voluntary community and social enterprise sector and the NHS. So we can then have that foresight. And I think that's a point, Becky, where we can then bring in some of these developing metrics. Kim, did you want to come on that point? Okay. Rob.
Yeah, so just to remind everybody that when we decided on the strategy and the board assurance framework, one of the big strategic risks is exactly the one that Becky described, which is the external factors are so great that we can't deliver what we want to around making improvements to people's life expectancy. So we do need to keep coming back to that. Now, one of the things that the board should keep in view is that the major conditions strategy is about to emerge. There's been a strategic framework published for that. The evidence for that shows what are the big drivers for early mortality. And they come down to behavioural, the way they describe them, behavioural, clinical, environmental. So the behavioural ones are the ones you'd expect, so smoking, alcohol, obesity. The clinical ones start with hypertension. And you'll remember at the last partnership board, I said to everyone should know your numbers because hypertension is something which causes early death. So we can do something about hypertension, and we can do something about diabetes and HbA1c, etc. And then the third group are about the cold, your occupation, and air quality. And our partners can do something about those things. But that middle group, what we might want to do as a strategic choice in the future is to say, given the context we're in, we might focus on the middle group. But that will be something we need to feed into our business plan for next year.
Okay, thank you. Becky, very quickly.
Just the LD health checks.
The LD health checks, I'd ask place leads to take that in. Yeah, and I think for you as new quality committee chair, I think there's oversight on that as well, of course. The other points you've made, I think, are just very helpful to absorb in and develop our reporting. I just want to get through the last few. We're aiming to try and finish in the next 10, 15 minutes or so, and we still have winter planning to do. So can we go Mel, Majid, Fatima and Kim? And if you, I'm sorry to ask you to make brief comments, but if you would. So Mel first.
Thank you, Chair. I just wanted to give the board assurance because on page 198 I can see that we haven't captured turning points IAP recovery figures. So I just wanted to share with the board that we were achieving 53.6% at the last reporting period, and I just wondered if there's a way we could capture turning point in this report moving forward in terms of their activity. I don't know if this is something other places are seeing, but interestingly, although we're meeting our national access targets for talking therapies, we have seen quite a drop in referrals in Q1. So we've just done a concerted effort with our PCNs to really push mental health support by talking therapies, and that has had an impact in the last 4 weeks in terms of number of referrals. I'm not sure at the moment whether that's just, you know, a Wakefield issue or whether that's something we just need to keep an eye on as a West Yorkshire.
Okay, if we can take that as an action, Mel, but I think this is helpful. And Anthony, again, grateful for your patience as we finesse this in terms of measuring to make sure that we get these things right. Majid, then Fatima, then Kim.
Okay, 2 quick points. First one, just building on the inequalities point. Okay, sorry. 2 quick points. First one, building on the inequalities point, the data, demographic data, whatever we can, we should start bringing it in, otherwise we won't really get a feel of the difference we're making on reducing variations and inequalities. So, and then the second point is on Ambition 8, diverse leadership. Really good to see the fellowship programme up by 200%, but we're still not where we need to be. I know we introduced this inclusive recruitment toolkit. It'd be good to get a feel of how that is working across the region.
Thank you, Majid. And I know we're also asking that through our partnership board as well, but I think we need examples of that. And I know, Kate, you'll be involved in that as well. So let's make sure that we programme that in going forward. Okay. And demographic, another point there on making sure we're bringing forward relevant demographics for reporting linked to variations in access, or good and bad, we need to understand. Okay, Fatima and then Kim.
So I'll be really brief. I mean, it's in response to Jonathan's really comprehensive financial briefing. And I don't think you can emphasise enough, Jonathan, just how challenging the financial situation is despite the best efforts of everyone around the table. I wonder, just being mindful of several media reports regarding investment and the sustainability of the NHS, whether we're being clear enough in our communications to the wider public about just how challenging the situation is. We've seen some of the benefits of community influencers or people amplifying some key messages about where this money is going and actually the impact it's making. And I wonder whether we could strengthen that to ensure that the public are fully aware that despite the financial situation, we're providing a really good service to our public.
Jonathan, I'll give you a moment just to prepare a response, and Kim, to you.
I just wanted to flag up on the risk register that you'll note 2120 that the risk of loss of VCSE services has gone down on the register. That is as a result of conversations about recalibrating the risks in relation to some of the other risks that are on there, not because we really think that the risk has gone down. In fact, in some cases we've discussed that it has increased and crystallised as more of an issue. So we're picking that up, we're having conversations, so I'm going to be bringing back a report on that. So I just wanted to flag that up. That's the reason why it's gone down.
Thank you, Kim. That's really helpful clarification. And then we can, as we're inviting Ian to come back looking at primary care, you gave us such a great report and the sessions that we had back in March. So invite you to come back again as well so we can track the story and also help and support you on sustainable commissioning for the medium to long term for the sector, which I know we're very committed to trying to achieve. Okay. Jonathan, are there any points there just particularly on what Fatima shared, and then we'll move on to winter planning?
Yeah, thanks Fatima. And in some ways it's similar but slightly different from the conversation that we were having with Kim at the last board meeting around can we get some clear messaging out to some of our partner organisations, particularly in the VCSE sector, around what it's feeling like financially wise in the NHS at the moment, and probably local authorities as well. And we said we'd do that after this meeting, because we're probably starting to produce more information in that regard for today. So I think we might be able to do something. I think we just need to be mindful not to be seen to be lobbying for increases in funding within the mandate that we've got. I think we just need to sort of strike a bit of a balance on that.
Okay. Thank you. Again, continuing to be open and honest. Mel?
I'm just really anxious for some of our voluntary sector organisations that are really struggling to meet the cost of living, staffing cost impact, and some of the challenges some of our organisations are making in having to go into, deficit conversations when, they rightly so want to pay their staff maybe a 5% increase, but we're not uplifting contracts at that level. So I just feel like that's a conversation we need to have outside. Perhaps me and Kim and other colleagues who are interested could pick that up. Sorry, that's not appropriate to say that. But
Thank you, Mel. And I think we've collected a list along the way today of things that we want to ask place leads and place committees to look at with their independent place committee chairs, as well as points that will come through in ICB committees. And then we'll make sure that comes back as a thematic update on where we are. But let's not wait for 6 months for a meeting. Let's have those discussions this week, this month. Okay. Thank you. I'm going to move us on now to winter planning. Anthony, thank you so much for this update. I find it really helpful, including that mapping of who's doing what when, which is really great. And also for anyone who has been tracking our work, we do have a document and report out in the public domain from our March meeting this year on our learning from 22-23 winter, and this is for 23-24. So what would you like to highlight with the board? And if you've got a question, please let me know.
Thanks, Chair. So colleagues have mentioned a number of times already today just how difficult last winter was, and clearly that demonstrates how important it is that we plan as carefully as possible to address the challenges we know will be repeated this winter. So that the purpose of this paper is just to give assurance to the board on the approach that we're taking across the whole system to plan for winter. It covers work across 4 broad areas. The first one is around, if you like, a staff assessment in places and organisations against a set of high impact actions that nationally we've been encouraged to look at, so that the paper sets out how the priorities have emerged from that work. The second area is around work on surge planning and looking at the additional capacity that we'll need in our hospitals and community services and care services in the winter. And just to note, the first iteration of our revised capacity plans have just been submitted to NHS England's regional team last week, and that'll iterate over the next couple of weeks in terms of further discussion with regional colleagues. The third area that the paper flags up is the work that we're doing to make sure that we're working as effectively as possible collectively across the system, and some of the arrangements we're putting in place to support the really good partnership working that we already have across places and our provider collaboratives. And then finally, there's a section on what we're doing to support the workforce in terms of recognising the pressures they'll be dealing with throughout the winter, and how we'll be supporting them, not least, of course, in ensuring people have the opportunity to be vaccinated against flu and COVID. So I'll just stop there, Cathy, in terms of those being the headlines of the paper, but if there's time for any questions, happy to take any.
Great, thank you. And Anthony, as we did last year, in our first year, that we'll have this as an agenda item as we go through winter, and then aim in March to have a reflection and learning, as well as we can talk about it in July next year as well. Because actually, Bev, you shared with us back in March that there was learning from winter that helped us with things like bank holidays and Easter, for example. So this is a point of continuous learning. We've got comments and questions from Harris, Rachel and Richard. So Harris, you first.
Just on the prevention point, I was recently reading the Kirklees Director of Public Health report, on poverty, and it stated how few people are taking up their NHS prescriptions and buying over-counter medication, and the rising number of people unable to travel to access healthcare or other support. This is only going to get worse in the winter, which will result in additional pressure on the NHS if they can't get the medication or get to appointments. So I'm keen to hear from public health colleagues about what other things we can do to ease pressure on the system.
Great, and not planned at all, but we'll now come to our public health colleagues. So would you respond on that first, and then we'll hear your query question?
Yes, thank you so much, and obviously thank you to Harris for reading the report. I think it probably links a little bit back to what Becky was saying about there's national policy and there's how we can or can't influence that, but then there's almost how we are understanding the impact of poverty and the cost of living crisis on how we're delivering our services. And I think what struck us about the report was the fact that people were, not reordering their repeat prescriptions as regularly as they could do in order to save money. And obviously, some of those things are quite invisible in terms of how we're delivering our services. So I think I've sent Jonathan some stuff that we've tried to do around an integrated impact assessment that looks at poverty as much as you look at things like equality and other protected characteristics. It's not going to solve everything, but I think that there's how we have a mind to that when we do things. And I think that certainly in the Improving Population Health programme, we've talked about how we take services to people at the times that work for them, because if people are going to be working, multiple shifts, complex jobs, multiple jobs, there's definitely something about, it's not just making sure a service is in place, it's making sure that people can get access to it at the right times. Because I just think that mitigates some of those cost of living and poverty impacts that might help and be the difference between a successful winter and perhaps not a successful winter.
Okay, thank you. Karen, do you want to follow up on that, please, very briefly?
Yeah, please. Just to say it's important that we make sure that all our colleagues understand that. If I think about some of colleagues in community who go into people's homes, often they are bringing blankets, and we've provided some. I know my colleagues in Leeds have done the same, but actually giving people the money to get on the bus to go to their appointment. Yeah. So to make sure that we all know would be really powerful, because we need to support our colleagues in that space as well as our communities. Thank you.
Okay, so we take that as an action, but that is something, again, that's going to happen this week, this month, and then we can hear an update on that back in November. And then seamlessly we come to you, Richard. I don't know if you want to respond on prescriptions and GPs as well as share your point.
I think I just wanted to remind the board, as Rob has done and Anthony has done already, that last year was one of the worst years that any healthcare professional has experienced, and we don't want to repeat that again. And so I am concerned that there is a lack or no investment in primary care services as part of the government plans and the ability for us to invest. Indeed, in Leeds, the same-day response service is being stopped rather than actually being expanded or increased. So I think we have real concerns about the lack of capacity to respond if there is a repeat of what happened last year. And whilst my general practitioner and pharmacy colleagues are busily vaccinating as many people as will come forward, and I encourage everybody to come forward who is eligible for vaccination for COVID and flu vaccines. Nevertheless, we are very worried about the impact of the lack of investment in an already overstretched service.
Okay, thank you. I don't know, can Jonathan, I don't know, you or Rob would like to respond, or Anthony? Anthony?
Yeah, thanks, Chair, and thanks, Richard. The approach to investment to prepare for winter has been different this year in the sense that it was all front-loaded in allocations rather than given as an allocation at this point in the year, which is what we've been used to. So I think that means there isn't any visible new investment, if you like, specifically for winter for primary care. I think we're going to have to look at this collectively across places and across the system in terms of the risk that creates and what that means in terms of where we might need to focus disproportionate effort to support primary care. So we'll take that away as something to look at as part of the next stage of the planning.
Thank you. Ian, did you want to come in as well on primary care?
Yeah, I completely agree with the points that Richard just made. We are hopeful that there may be additional funding for acute respiratory infection hubs for primary care, as there was last year. Still conversations going on about that, but we think that may be additional to the 200 million that's been identified.
Okay, thank you. Colleagues, are we happy to support this plan and to continue having this as an agenda item going forward? And actually, in between then, there is so much work that will go on week to week, and I think a recognition of chief operating officers working in the system, which are key people who help to make this happen. And we'll hear more as well about the role of the ambulance service, as well as working with our variety of provider collaboratives, including community and our acute colleagues. Okay, thank you, Anthony. That's really helpful. I know we've got to meet an NHS England requirement, but I'm really pleased that we had conversations about issues around poverty and bringing in our public health colleagues as well. Okay, thank you. Something that I just need to do in going back in item 9, we have a dashboard. Anthony just gave an overview of how the dashboard's working going forward. I think if you've got any feedback or any particular metrics, please let him know. But we're happy to receive this format. So some meetings we're going to see the overview as a system. Sometimes we're going to see ourselves benchmarked against other systems. Are we happy to take that going forward? I can see nods around the table. Thank you. Okay, we then have our committee AAA reports. They've been referenced throughout. There was a point earlier that was made around learning disability assessments, for example. We note, particularly across place committees, you're all looking at financial pressures and challenges, as well as other elements. And I can see deep dives going on, as well as continued commitment to listening to local citizens and communities, which for me goes all the way back to item 5 today about making sure we've got people at the heart of decision making. I'd encourage colleagues to particularly say, for example, on Quality and Finance Committee, to talk to those place leads and gain that information. Is there anything pressing from those reports, or can we take those as read? I'm going to take those as read. Okay, and I think there's oversight AC in terms of the ICB Finance Performance and Investment Committee about having that oversight by place, as well as, of course, by sector as well. Okay. Thank you. We then move on to a governance item. Laura's just going to give us a quick update, but you're being asked to approve these documents, board colleagues. Laura.
Thank you. Yes, so part A of this report is asking for approval today to make some amendments to 2 of the ICB board's committees. The first one is the Transformation Committee. I would say that the committee is continuing to evolve how it's working, so this is very much an interim request to amend, and I think you will see them again with some further amends, possibly at the next meeting. And the second one is a request from the Bradford Districts and Craven ICB Place Committee, who are seeking to amend their membership, so seeking approval for that, please.
Okay, colleagues, are we happy to approve those documents as they are today? And I know with the Transformation Committee there's continued work. That's transformation for you, isn't it? So you're continuing to come together on the development of that. Okay, thank you. Also, good governance as usual. Is there anything else, Laura?
Just the second part of that item, if I can, please. This is asking the board to support the setup of it. It says joint committee. It's not strictly speaking a joint committee, but it is a committee of multiple places in line with the arrangements we set out in our governance handbook 12 months ago. This is the first time we've asked for this. Setting up a joint committee of 3 places to manage the future governance, supporting the future phase of the Calderdale, Kirklees and Wakefield Older People's Inpatient Transformation Programme. It's in line with what we said we would do, and you're being asked to endorse that recommendation to establish the committee. You'll see within the paper that place governance leads are still working with place chairs and accountable officers to confirm nominations to the joint committee. I think 2 of the 3 places have now done that, and that you will receive minutes from that subcommittee in the future for continued assurance.
Thank you. Colleagues, are we happy to support that? Yeah, round the table, thank you. I think my request is ICB chair is that particularly for that the setup, there's a regular update to you and I, because this is a different kind of committee and we can see the purpose of that. I can see my name on there as well, on my job title. So I think there's just an update on how that's working and an evaluation of its effectiveness, as we do for all other committees as well, but happy to approve. Okay, thank you. I haven't received any other business. And I assume we don't have anything. Rob, do you have anything? No? Okay. Colleagues, thank you so much around the table today for our guests and visitors who've joined us in person today here in Bradford, to the people who joined us for our engagement session on looking at mental health. What I would say is if anyone has been affected by the topics we've talked about today, whether it was in the engagement session or around the table here today, we'll make sure that there's information out there, but please go through and seek support through your networks, and also we'll put some information online as well to provide support as well. Thank you, colleagues. It's been a long day already. We will now close our board meeting in public, And thank you to anyone who's been watching online live on record. Thank you very much.